Okay, thank you. Okay, so to begin with, I have no financial conflicts of disclosure to reveal. So the objectives. Why delay cord clamping at all? Now, maybe that's a question that seems obvious. We've been delaying cord clamping or deferring cord clamping as the more common terminology or the more recent terminology has become for some time. A question that really comes up, and I think I'm glad I'm here with Yaya, because Yaya may remember in Winnipeg, we introduced cord clamping and said it should be for a minute. I remember one time, Yaya was very ahead of his time. Yaya wanted to clamp for 2 minutes. And I remember saying, I think, I've seen the evidence. We're not there yet, but he wanted to get there. And it's funny because we pretty much have gotten there. And here I am talking about something even past 2 minutes, as you'll soon see. So then the next thing is we're going to discuss what is physiological cord clamping, because that's really something that I think you're going to hear a lot about in the next few years. And then why might it be better? So I was overjoyed to see a dog in the previous presentation, and I thought, wow, we're going to keep it going. And because the last speaker couldn't connect, and I really hope and pray that he can, because I'm looking forward to the talk, maybe there'll be a dog in that one as well. But what is natural? Because when you think about it, in the animal kingdom, they defer cord clamping, right? There's no timer, there's no dog or elephant that has a watch on and says, okay, it's time to chew off that cord. No, it generally stops pulsating, and then it's separated. And when you look at, even depictions in art, this mother unfortunately didn't make it, but that's what the painting's about. But back, in ancient history, well, I don't know how ancient this is, but hundreds of years ago, clamping was different. There was no rush to clamp. But so why did we start cutting early? So this is a graph that I think no one will be surprised at. This is the estimated global births, and you can go back towards it goes back to 1800, and you can see, and we know there's population overcrowding and so forth, but you can see that the population is rising rapidly. So when you think about why did clamping start so early, and I trust many of you will say you already know the answer, this was a modern obstetrical intervention. Okay, you had multiple deliveries. And now I come from a city of about 800,000 people. When you're in, I don't know what somebody told me the population of Dubai is 8 million or something. Is that true? That seemed rather large. Okay, but it's much larger, I think, than Winnipeg, or at least maybe it seems. Or let's go with Mexico City. Mexico City has what, 25 million people or something like that. When you've got that many people, that many births, the obstetricians simply had to go around cutting the cords early because they had to go from one place to the next. They couldn't wait for things to separate. So there's a bit of a logical fallacy there that becomes, we're clamping early because we're going from one place to the other, and we assume that that's okay. Okay, and now I presume this audience is very well educated. You understand that assumption probably isn't fair. Okay, and we have some evidence to support that. So what is delayed? And as I say this, I can already think of my co-author for the CPS, Canadian Pediatric Society statement. Sarah and I authored it together along with some other people. I can already hear her slapping my wrist and saying, stop saying delayed. Delayed, the reason, for those of you who don't know, the reason why delayed has fallen out of is because delay implies that you should have been doing something, right? And you were lazy, right? You delayed. Whereas deferred is more of an intentional thing. You're deferring the clamping, okay? But so wherever you see delayed, and I'm slapping my wrist myself, just replace in your brain deferred. So generally, it's a length at least beyond 30 seconds after delivery. It's very between 1 and 3 minutes for most of the literature that is out there. And again, yeah, you were ahead of your time when you were saying 2. You were right. I finally admit it. Right. Okay. Anyway, actually, maybe you were wrong. Maybe it should have been even longer, as we'll soon see. Yeah. Yeah, at least. Well, that's interesting. I won't be at 10 minutes yet, but you'll see. Anyway, so growing evidence that longer is better. Okay, so why delay deferred clamping? So as I mentioned, I had the great pleasure of working with Sarah. Sarah is an obstetrician in Hamilton, Canada, McMaster, and really she is really well articulated. And if I would really be giving the talk, because she really was the driving force behind umbilical cord management in preterm and term infants. And so we'll summarize the statement in a little while, but this statement actually, I don't know what it's like over here, but it took an incredible amount of coordination, because Sarah was with the Society of Obstetrics and Gynecology of Canada. She was the author from there. I was and still am, the chair of the Fetus and Newborn Committee. And those two organizations published together was very difficult, but we managed to do it. So this was co-released by the two organizations. So to summarize a little bit of what we know about cord clamping, benefits of term, and again, many of you will know this, but increased iron 6 months may lead to less, but also you have that placental transfusions, so less early anemia. If clamping longer than 1 minute, this may increase the risk of hyperbilirubinemia, which is not surprising. The bigger blood volume, the greater the risk of hyperbilirubinemia, but less anemia. Now, if you were in a place where I live, we have a significant problem with our indigenous populations in the north of Manitoba, which are it's dark for much of the year. There's less nutrition, so we have vitamin D problems. We've got problems with anemia. We have problems with proper nutrition, so we have a lot of milk consumption early, less breastfeeding, which leads to less iron stores. So deferring cord clamping could be of great benefit to them and perhaps other populations that are similar. Now, what about if you're preterm? To that, I look at the Cochrane review, which is generally looked at early cord clamp, generally defined as less than a second, two times somewhere between 30 seconds to 180 seconds. Cochrane review from 2019 used 30 to 60 seconds as the range. And thankfully, this is not my terminology of delayed cord clamping, but they referred, they looked at 25 studies with 3,100 babies, which is actually not too bad. For neonatology, I mean, when you look at adult cardiology studies in the tens of thousands, I mean, that's a big study. But if we can get 3,000 patients together for neonatology, that's not bad. The outcomes are tiny, so I'm going to read them to you. Is up my 25 minutes. But if we look at, these are for preterm infant, between seconds to 180 seconds, leads to a reduction in the relative risk for death of babies, which is obviously a very, very important outcome. The other one that's statistically significant is any IVH. Now, when you look at severe IVH, that crosses that threshold of 1, so we don't see a statistical reduction in that, but any IVH will be reduced. And I would argue the real important one there is death. Now, what about the CPS? So when Sarah, myself, and others reviewed all the literature on this, and I'd like to say we did I think, a fairly exhaustive search of the literature. What we concluded is different than the Cochrane. This is the Canadian Pediatric Society. We agreed that there was a decrease in IVH. We also found that there was a decrease in necrotizing enterocolitis, which is obviously a very important outcome. We also identified that there's an increase in the mean arterial pressure, blood pressure, decreased need for blood transfusions, particularly in the preterm infant, and decreased inotropic support. And as I think about, my career in neonatology, which now it's almost 25 years already. It's hard to believe, but when you think about it, I recall, and I'm sure many of you who have been in the field for a long time, I'm looking at yourself as well, having trained in Winnipeg, we used to start dopamine, dobutamine, epinephrine, norepinephrine all the time, on these little babies, okay? And I seldom anymore am starting these medications on newborns. Yeah, and I think in large part, it's because of that deferred cord clamping. So I think this is an example where what we see from the research really translates into our clinical experience. Okay. So I think that that's very, so I put here a little light bulb with a good idea, because I think that deferring cord clamping has been one of the. All right, now on to physiological-based cord clamping. I guess, I was worried about going much beyond a minute or a minute and a half. Because what we think about is we think about this poor baby over here who needs to be resuscitated. It's our instinct. We want to resuscitate the baby, right? And so you better cut that cord and bring the baby over and start your ventilation and chest compressions if needed. But maybe there's another way. And so when I started to read about this as part of the Canadian Pediatric Society statement, I started to realize, there's some research here that has some important lessons that we can all take as to why maybe deferring longer and maybe even resuscitating while the baby is still on the cord is the way we need to go. Now, we all know that about 10% of the cardiac output goes through the lungs in the fetal state. Okay. After birth, we know that as air enters the lung and the lung expands, we see a drop in PVR and blood flow to the lung improves. The question is, what happens if you clamp that cord before the pulmonary blood flow has increased? Okay. So you've got oxygenated blood coming through the umbilical vein, perfusing the coronaries. If you suddenly cut that cord, what is that going to do to coronary blood flow? What is that going to do to oxygenation if the lungs are not yet ready to receive blood and oxygenate? As you might expect, that can lead to bradycardia. Okay. And so I'm not sure whether this is a southern hemisphere swirl or a northern hemisphere swirl, but as the water goes down the toilet one way or the other, it's like you're going down the drain. So you cut the cord, and then what happens is you get this loop, okay, where you get with decreased ventilation or even a drop in PaO2, that leads to bradycardia. That leads to a decreased arterial blood pressure, leads to decreased cerebral blood flow, leads to more CNS hypoxia, which it just goes around and around and around. So if you cut too early, that's the problem, is that you can enter a loop where the hypoxia, the acidosis gets worse and worse, and it just goes in a continual loop. So the idea of physiological-based cord clamping came actually from, I think, I hope I'm not incorrect and somebody's going to jump out and say you're wrong, but in essence, it came from this study which looked at umbilical cord milking, but also physiological-based in sheep. Excuse me, out of Australia, 126 gestational age fetal lambs, and they were able to do something that we can't do in clinical studies. They were able to put pulmonary blood flow catheters, measure pulmonary blood flow, measure systemic blood flow. And what they found was something very interesting. What they found, and this is on the left, this is what the study is very detailed. And so I have many graphs demonstrate PBCC. So on the left, what you're seeing is they would start resuscitating these fetal lambs. And you could see you don't get on the y-axis is mils per kilo per minute in measured pulmonary blood flow. You actually don't get significant pulmonary blood flow until after that 2 to 2.5 minutes. Okay. Secondly, on the right there, you're seeing a whole bunch of different curves. It's a bit of a mess, but the one that I want you to pay attention to is the red one over here, the top one. Basically, what that's showing is that when you do PBCC and you compare that to umbilical cord milking, the SCTO2 is the cerebral perfusion or cerebral oxygenation, sorry. And what you're seeing is you get the smallest change with resuscitating with an intact cord, even compared to early clamping, even compared to umbilical cord milking. In the Netherlands, this is where the center of all this research is. This was a pilot study, a clinical study by Brouwer from 2019, and they built the Concorde. The Concorde, for those of you who don't know, this is a resuscitation table meant to be able to allow physiological-based baby. Bit cumbersome. I was amazed for the women in the audience. I'm amazed that women would have agreed to this, but right after birth, they asked the woman to lift her left leg, okay? And they would slide the Concorde in, and then she could put her leg back down. I would imagine many women would be quite exhausted after giving birth, and the idea to ask them to lift their leg was something, but Many women agreed to do this. There were 82 mothers and 37 preemies who agreed to do this. And they clamped the cord after the following three criteria were met. Adequate breathing, they had a mask that allowed for measurement of exhaled volume. So once they had over 4 mils per kilo, a heart rate over 100, and a SAT greater than the 25th percentile using by minute, using an oxygen less than 40%. The results, mean time of cord clamping. So in order to get that stability, they defined a stability transition after birth was 4 minutes and 23 seconds, a low of 3 minutes to a high of 5:11, a little short of 10 minutes, but still quite a bit longer than we're currently doing. So what this is meaning is you weren't actually stable. Now, they didn't have pulmonary blood flow cath or flow probes, but they were able to tell that these patients were stable. Only one patient had so when you left these babies out for 4 minutes, about 50% of them had an admission temperature. This was followed up in the same group, Ronnie Knoll, Emma Brower was the second author. She was the first author before. What they decided to do is let's expand. Early cord clamping, cord clamping. And so what they did was they compared now 30 to 60 seconds. So they didn't go with early cord clamping because they said ethically, no one's doing early cord clamping. So we should compare it to deferred cord clamping of 30 to 60. And they looked at less than 32 weeks, non-inferiority. They used stability of 75 seconds. That would not be crossed. And you'll see in a moment what they found. Primary outcome was very similar to the previous one. They said you had to have regular spontaneous breathing. So they switched it up a little bit. They got rid of the mask exhaled volumes in favor of the baby had spontaneous breathing. They had to have a heart rate greater than or equal to 100, and they needed a saturation above 90% with an FiO2 less than 40%. I like this outcome better because, to be honest with you, who could remember what the 25th percentile was at any given minute? So they just said, let's make it more practical. And in the PBCC arm, they clamped when all criteria were met. The trial was stopped. It was, as many trials, poor recruitment. So they stopped due to, but they had enough babies. They were able to do an interim analysis, and lo and behold, they found that they had already reached the endpoint. They were able to show that even if they had added more babies, it was not going to change the outcome. Deferred cord clamping of 30 to 60 seconds was not deemed to be non-inferior. So in other words, PBCC was found to be superior. The mean time to stabilization was 5.54 minutes in the PBCC group, and it was 7.07 in the deferred. And so just a couple more, I think about 3 more slides. One thing that was noted here, and this what comes up in the CPS statement, and this is an example of statistical difference, which maybe isn't clinically different. The CPS statement does talk about the fact that cord pH is lower in those who get PBCC. But when you look at the data from this study, and this is where it comes from, cord pH was 7.21 in the PBCC group, and it's 7.29 in the deferred group. So clinically, I would argue really not significant, but statistically significant. The other thing that's interesting is you're more likely, and this has been replicated in other studies as well, more likely to get prolonged if you're under PBCC or be ventilated at all, if you're clamping late. So what's coming? I said at the beginning that this was going to be something that you're going to hear more about. There's 2 studies. I won't go into detail due to time. I realize I need to wrap up, but one of them is called the SAVE study coming up, SAVE. The other one is the ABC trial. Now, interestingly, it's ABC3 trial. ABC1 was the Brower trial. ABC2 was the Ronnie Knoll trial. This is now ABC3. So they've tried, it's like a story that they keep building. And what they're going to be doing, in these is really looking at, again, the use of CARTs, prolonged resuscitation, and build on the evidence. So I expect we'll have a Cochrane review before long on that. this must be something that is going to take, because there are companies now producing the LifeStart and the Baby Saver are um, two different products that are on the market or coming to market. I don't know if they're commercially available everywhere yet, but the Baby Saver in particular, if I was to ask you just to look at these and say which one's more expensive, you're going to say the fancy one on the left. And you're right. The one on the right, Baby Saver. And really, finally, before we get to our conclusion, these are the things that we don't know yet. So we have short-term outcome things that we are looking at, like pHs, temperatures, and whatnot. But at the end of the day, will PBCC be superior when it comes to things like necrotizing enterocolitis, jaundice, anemia, IVH, blood pressure, than to delaying? And so, in other words, will yaya be correct? That's really the question. Will it be 2 minutes? Will it be 3 minutes or more? CPS position statement. This is ultimately what we said in summary. And I'll just summarize it briefly by saying we basically said that yes, PBCC is being done. Yes, there are some studies, but we still need some more evidence. We are concerned about the hypothermia risk, because hypothermia also carries its own risks. We are concerned as well that with PBCC, virtually 100. So that's another question of, are you going to increase the risk of kernicterus, let's say, if it goes unrecognized? So that's something that needs to be done. So in conclusion, early cord clamping, while convenient, has its disadvantages. Deferred cord clamping is better at achieving both short and long-term outcomes compared to early cord clamping. But we still have work to be done to determine if we're ready. Anyway, thank you.